It is day 2 of BFRB Awareness Week. Is that right? Yeah, it's October 2nd, day 2 of BFRB Awareness Week. I see Mercedes joining,
Fantastic.
who is one of your uh, research students. Is
Yes.
that?
Yeah, one
Yeah.
of my students. Yep.
Um, and so BFRB Awareness Week is all about raising awareness of BFRBs, which stands for Body Focused Repetitive Behaviors. And so today I am here with Dr. Mike Twohig, who is a clinician who treats BFRBs and also a researcher at Utah State,
That's right.
um, conducting research on BFRBs and how to improve treatment. So we're going to just dive right in.
All right.
I've had the pleasure of working with Dr. Mike on bringing continuing education trainings to treatment professionals. And so super stoked for this interview because it's all about integrative treatments, and I can't wait to share what you know because you know a lot.
Oh, thanks.
So first, how did you learn about BFRBs and get into this world of treating and researching them?
Yes. It's been a long time. So about 1999, I was I was an undergraduate working with a guy named Doug Woods. And if you're in the BFRB world, that name probably means something. And so I ended up doing my master's with him. I was his first graduate student. So really I got introduced to it by my master's advisor. And then I've never stopped working in that area. I really find it to be a fun challenge. I love the people I work with. There's always been a lot of work to do. We've never figured out the solution. So, I've always felt busy and entertained. So, yeah, I've been in it for about, I guess that'd be 26 years.
Oh, wow. That's without me doing good math, that's probably how long I've been pulling out my hair. Maybe maybe a little bit less. Um, and fun fact, Dr. Woods is actually our Habitaware's first phase 1 research grant was with Dr. Woods' um, research university. So
Yeah, I would imagine.
love that, yeah. So I love that that came full circle in a sense of this
That's right.
community.
Hmm.
So that's amazing. So you walked into school one day essentially and were given this task and said, "This is cool. I'm going to stick with it."
Well, I mean, if I can add, I'll elaborate more on,
Yeah.
the thing I started. So the very first study I did was on nail biting, and help people reduce it. And weirdly, that we were fairly successful in sort of a short amount of time. And that was one of the times I learned BFRBs are more notable than I knew. The participants who came into the study with their nail biting, it was different than I thought nail biting was. It was just more severe.
Mm-hmm.
And so then the next step was I got participants with trichotillomania, and I did a small study with them. And I remember I went back to Doug and I said, "Doug, it's interesting. We can teach these participants these behavioral procedures, but they have a hard time keeping them going. Like they say they're overwhelmed. It's, if people have learned habit reversal, they can do it, but it's hard to keep it going. They don't feel motivated. They feel too much like they feel a lot of annoyance and pressure and, all this stuff while they're trying to do the procedures we teach them." And I said, "How do you handle that?" And he said to me, "It'd be really neat if we added acceptance and commitment therapy." And I was like, "What's that?" And he's like, "That guy Steve Hayes." And I was like, "Oh yeah, I like him."
Mm-hmm.
Like, that would be a really cool thing to add to this. So that was in, I think, 1999 or 2000.
Okay.
And then we went out and got trained in how to do acceptance and commitment therapy in 99 or 2000. And, those researchers who know this or have like read our books or stuff, that ACT plus behavior therapy has kind of become a big treatment in BFRBs in general. We've done a lot of work with skin picking and hair pulling in that area, but that all just came from, us talking about like what seems to be needed. And again, if you go back to like 2000, there's just like not much, right? So it was like,
Right. I want to back up a little bit. You mentioned habit reversal training. Can you talk to what that is and then also what ACT, acceptance and commitment therapy are as well
yeah,
for folks like me who don't know specifics.
Yeah, so habit reversal is the traditional first behavioral procedure used to treat what they called in like the 70s habit behaviors. And interestingly, it's pretty powerful, but not kind of not a full treatment package. I think anyone who's working today is using other cognitive procedures with it, but it is a really nice intervention to get a, like when I do it in my studies or clinically, it's basically teaching people to become aware of the habit. You make fists for a minute contingent on it, and you get some social support. And it appears that just learning how to wait some time from the urge to do it or the beginning of doing the behavior, and if you just wait some time and make fists for a minute or longer, that breaks kind of a cycle and helps people get control. But then you're still left with the pulling where you see the hair, it's the annoying hair, you can't just let it be, it bothers you all day. And that's where we added these cognitive procedures. That's the acceptance and commitment therapy. Other people do other cognitive procedures. But in ACT, we call it ACT because there was already an ACT. In ACT, we basically teach people to notice their thoughts, feelings, and urges, practice seeing them for what they are, allowing them to just be there, connecting with why it's worth doing, and daily making steps to, get better at this. And that combo seems to target the simple repetitive behaviors and the really complicated cognitive behaviors.
Okay. So sort of starting with HRT, habit reversal training, focus more on the physical behaviors, inhibiting that in a sense, and now adding in ACT as a way to sort of integrate other modalities of care.
Yes, and it's sort of recognizing that in almost any behavior, not even just hair pulling, skin picking, and other BFRBs, in most behaviors, there's the skill change that we should learn, but then there's what do we do with the thoughts, feelings, and emotions that don't agree with us changing our behavior, and then we offer the client some skills of what to do with thoughts that are hard for you or emotions that are hard for you.
Okay, so recognizing it's not just a physical behavior, but there is that mental, thought-based component as well as that emotional component, and also the sensory component too of like.
Well, that's absolutely true.
Yeah. Yep.
Yeah.
Okay. So how did you go from HRT, studying HRT, saying, okay, this isn't the whole picture, looking at ACT, and sort of where are you now in sort of what you see as useful to someone with the BFRB in terms of the treatment modalities?
Right. So we've been researching ACT plus habit reversal. We call it AEBT, ACT Enhanced Behavior Therapy. We've been researching that for a long time. I think, in some of the more recent reviews we've done, there's about 18 outcome studies on it. Some are big trials, some are smaller trials. And then we've been trying to figure out how to build out the whole package. So that those are some of our studies. And then now that we know it's useful, now it's like, well, how do we get this into the hands of people who want it or get it into the hands of clinicians? So we've been building out a lot of training programs, testing training programs for clinicians. We have been we've built web-based interventions that people can just log into and do. Those are publicly available now. So we have one for hair pulling, one for skin picking. We test those. We've tested them in different ways. And they're actually quite helpful to people.
What sort of outcomes are you seeing on your sort of e-learning platform for people with these conditions?
What we see is something in 50% of people hit a responder rate, which doesn't mean zero. It means they've crossed sort of a threshold from one level to a notably lower level. And in my opinion, that's pretty impressive. If you think of it as part of the treatment, right? So you do that first, you get a nice bump, you learn some skills, you go practice that, and then you kind of figure out what you want to do next. So we just keep building that out. We have we have book manuals that clinicians can use. We have a book coming out for clients. So just trying to get it out to, clinicians and people who want the material.
Yeah. I mean, I think the work that we've been doing at Habit Aware is sort of started out focused on the hands, right? The movements of the hands, building awareness of that. but then using that to get awareness of the mind-body connection, the thoughts, the feelings, so that you can start learning to replace. So I love that, like, so many different seeds have been planted and so many different ways we're getting to some of the same answers around how to create lasting change. And
That's
so
right.
that combination of HRT as well as ACT.
Yeah.
And someone in the chat just asked, "What is ACT?" one more time. So do you mind just
Yeah.
repeating yourself for that?
It's a form of cognitive behavior therapy called acceptance and commitment therapy. It's just sort of the modern take on traditional CBT, which is a little more acceptance, mindfulness based than more direct cognitive change.
Yeah. So it's looking at your thoughts and how those thoughts influence your behaviors.
Yeah, and getting better at noticing you're having thoughts and urges and then choosing what to do with them. So, like, I'll just give uh, an example. What do you call the bracelet? Do you call it habit aware or keen?
Keen to, yep. Keen
Okay.
to.
So, I will sometimes tell one of my private clients, I mean, we don't incorporate it into our studies, we're doing those a certain way,
Yep.
but I'll talk to them about wearing one because the way I think about it, they get their hand up, they get some warning that you're, and then the body's like, well, you're not done. Like, you went up to do something, or you saw something, or you felt something, and then that's where we use the ACT strategies. Like, how do you not finish that thing you wanted to do, or have this feeling that now is uncomfortable and you'd like to do something with it?
Yep.
And then use those strategies.
Yep. Yeah, exactly that. That the bracelet will vibrate, make you aware. And then, yeah, it's not just put your hand down, but it's kind of complete the cycle, but complete the cycle in a healthy way, right?
Yeah.
And by doing that analysis of what am I thinking, what am I feeling, to try to meet that need in a more targeted way so that it does satisfy, and then you can kind of go on with your day.
Right. Yeah, honestly, there's if you can make it a few minutes from the moment you really want to do it, you're like not just that the desire drops, it's that how caught up you are in the cognitions tied to it, they will really adjust or become easier within just a small amount of time. But people, waiting that 3 minutes is something that's hard for people to do. And that's where some of these cognitive strategies jump in. They can make it a little easier, give you some techniques to use in that time.
Yeah, 3 minutes is a hard challenge.
Yeah.
We live in a world where things are happening too quickly. I feel like that 8 second, what do they say? People have 8 second attention spans. Like, I don't know, 3 minutes.
It is true. Like, I try to brush my teeth and not look at my phone, and that's 2 minutes, right?
Yeah.
And it's hard, but I would, to those people who are listening, I'd say, building up that skill is
Yeah. That might be a good way to practice.
I do.
Yeah. So Sahib asks, what would be the first basic step towards habit reversal if someone has trichotillomania? How helpful would it be to set a target?
Okay. So if I had to give a little thought on habit reversal just over, without seeing this person in person and being able to explain everything, I'd say that what habit reversal is, I think at the core, is you are purposely doing something else for a whole minute. And what you're kind of saying, Anila, is it's hard for people to, just wait 10 seconds. So when you have a strong desire to go up and play with your hair or check for something, whether it be skin picking or nails, when you have a strong desire to look for where you're going to pick or pull, if you can somehow say, I'm waiting a minute before I do this behavior, and I'll check how I am in 1 minute. That's kind of what habit reversal is. It's just we give you a particular thing to do. We say make fists, or hold the steering wheel, or hold the book, or purposely do something. I think you're waiting that amount of time. I mean, if I had you hooked up to a bunch of like physiological recording, I bet you go from strongly tied in and interested to in 1 minute halfway there. Like, I bet it's like a 50% drop, and then it's like a lot easier to pass.
Okay. So sort of urge surfing is what you're, yeah, okay.
Yeah, but it's easy to not get distracted in that minute.
Right. Urge surfing plus also doing something that kind of blocks the hands from engaging, from doing the pulling behavior. Okay.
Mm-hmm.
So that's
Mm-hmm.
habit reversal. And the second part of that question was how helpful would it be to set a target? So I'm guessing that's kind of like a measurement, and maybe that's the time that you're mentioning.
Yeah, it could be. And if the person who posted it is getting at like a pulling or picking rate, um, we do that a lot in our work. After people learn the skills, the behavioral and cognitive skills, we then say, well, let's create opportunities to practice this by agreeing to like lowering rates or periods that you're not going to pull. This is like your practice time.
Mm-hmm.
And what I'd say is if you choose to do that, make it an amount that is within your ability and you can do it with good form. So I use the weightlifting analogy a lot, which is, weightlifting with bad form, you might as well not do it. But weightlifting with good form, even with super light weights, is helpful. So if you're going to challenge yourself at an amount where you can, sort of openly practice having the desire to pick or pull. Don't just do something you have to tough through, because honestly, toughing through moments is not really therapeutic. I mean, we all have to do it sometimes, but I think if you can really watch your thoughts and feelings, connect with why this work is worth doing, and just be there for it, that's where it becomes pretty therapeutic.
Yeah. Wow. We just got a bunch of folks coming in, so let me reintroduce Dr. Mike Twohig out of Utah State, both researcher and clinician and expert in BFRB treatment. And we're talking about AEBT, which is Acceptance Enhanced Behavioral Therapy, which is sort of the next wave of gold standards of treatments for BFRBs that combines habit reversal training, which was the sort of original initial treatment for BFRBs, with acceptance and commitment therapy, which integrates more mindfulness and looking at thoughts and feelings as part of that whole mind body behavioral treatment, if you will.
I think you said that wonderfully.
I'm getting there. I'm getting there. It's super, super exciting to be talking with you. I know you're doing a lot of different research on BFRBs. Um, One specifically on actually a e-course that you've put together for people with the condition to learn AEBT on their own and practice it. Tell us
Right.
a little bit more about how that came to be, and you did talk a little bit about the
Yeah.
outcomes of that, but like what can people expect when they go on the website and access that?
Yeah, I'm glad you asked that question. These are really fun for us to build as researchers. So part of our lab, so there's multiple PhDs in the lab and multiple graduate students working in the lab. We build these web-based interventions for different problem areas. Now, my favorite areas to work are trichotillomania, skin picking, OCD, that type of area. So the team got together and built them out for those particular BFRBs, skin picking and hair pulling. And what we really try to do is we want to design the programs that match the type of people we're working with. So, we have to think about, are these people who'd like it by video? Are these people who'd like it by text? Would you like a lot of exercises? Does it have to be heavily behavioral? Should they be short? Should they be long? And I have a good understanding of trick and skin picking. So take the manual and make it into a web-based intervention. I really try to make it sort of fit the people who are going to be using it and be the type of thing that they're looking for. So I think they are all 6 or 8 session interventions, and the sessions are like 15 minutes, self-paced. So you get on and you sort of click through the work, and they're interactive to keep you engaged. So it's set up that works well on a phone, it works well on a computer, and it walks you through all the work. And then it always gives you kind of like a challenge. So you wouldn't do all 6 in a row. Gives you a challenge, and you work on this for a few days, and then you move on to the next thing. And then you have it. I haven't seen if people do this yet, but I could see if you went through the whole thing, you could wait a minute and then go through it again and kind of see it with different eyes, because it's, you could just see the skills a different way and keep practicing them.
Okay. So it seems like a very step-by-step e-course
Mm-hmm.
through learn something, apply something,
Yeah,
test it out for a few days, and then go back and do kind of the next step
that's
sort of thing.
exactly right.
Cool,
Yeah.
awesome. And where can folks find that? Is that just, what website would they go to for that?
Yeah. If I type it in, is that easy?
Oh, you could put it in the comments there.
Yeah, I think that's the
Um,
easiest. I mean, you'll have to.
yeah, you can also probably just do a Google search for Utah State Trichotillomania Twohig course, and I'm sure it'll come up.
Yeah, if you go to there, that's our lab's
There
website.
you go, utahact.com. So check that
Yeah,
out.
there, there's something that says like treatment, and then you click on that, and you'll see.
Yep.
Yeah.
So tell me, what else are y'all researching on BFRBs right now? Now that that's kind of out in the world.
Yeah. We do things around, you know, I don't know if we do so much on like why do BFRBs occur. Oh, it's funny. I think one of my students, Mercedes, is on
Yeah.
here. I should tell her to come up here. She does really cool work. So I'm actually going to describe some of her studies. One is we built a training course for clinicians, and then we trained 100 clinicians on how to treat BFRBs, but we did it in a treatment wait thing. So we trained the first group, and then we followed them for 6 months with like not weekly, monthly sort of consultations to keep them going. And then we trained the second group of 50, and that was cool because it showed if you learn this program, you do become a better clinician. You know more about trick. You know how to do the interventions. We couldn't track outcomes because there'd be like a second step to track the client. But they were out there getting more clients, and it was that was really a fun study. Like I felt really good about that because having 100 more therapists, and we actually just did it in Utah. There was 100 more therapists that who all, I'm not saying they're great now, but they went through a whole course and had 6 months of consultation, so that's good.
They're better equipped than many. Actually,
Yeah,
that kind of reminds me when we first sort of started chatting, maybe like a year or so ago, you had mentioned a different research that you had done in terms of like awareness of BFRBs amongst treatment professionals. Can you speak to that one a little bit?
that's my student Lila Capel. She ran that study, and this was really kind of fun. We did a survey of all the health providers in the state. So we picked categories, but the bulk of them, I think we sent out like 8,000 requests, and they responded across all these questions of like, can you diagnose BFR? We just did skin picking, hair pulling, but can you diagnose? Do you have good treatment plans? Do you know what's comorbid with it? Do you understand psych interventions and medical interventions? So it's basically like, does the community understand what to do? And as you can imagine, the answer is like, by and large, they do not know what to do and have the wrong ideas. And that was okay. I mean, in a way, that's what I expected. But that sort of justified the next study that like people don't know. So it would make sense for us to start training people.
Yeah. And that's great because you have from those 8,000 people saying, I don't know, and now you can go back to them and say, come
Yep.
join this study, we'll train you. And for folks with BFRBs, this is why we do BFRB Awareness Week, right? Because even the treatment professionals don't know
Right.
sometimes, right? And so sometimes we need to be our own advocates. So if we here can give you information that you can then take to your treatment professional and say, hey, I heard on Instagram,
Right.
AEBT, from a doctor that's treating patients with BFRBs, that's researching BFRBs, and go to your clinician with that information, then they can take that homework and go research it, go understand it, and
Right.
implement it.
Right.
And so Awareness Week is all about trying to help people understand what these conditions are so that we can be met with more compassion. I have hair pulling disorder. You wouldn't know it anymore because I've solved it in my own way as I'm patting my little Keen 2 bracelet that we've invented.
Yeah.
But it allows people like me to be met with more compassion from our friends and family. And then it also Awareness Week allows us to get that education out there. What are the good treatments? Who are the right treatment professionals to look for trainings like Dr. Twohig, whom we worked with through BFRB Changemakers nonprofit to get this treatment, this AEBT treatment to treatment professionals. So they have good information to treat people like you, right?
Hmm.
So Awareness Week is really, really important. We're trying to get the word out, and I want to encourage you listening to also hit share on a habit aware post that's explaining BFRBs so that your friend circle starts understanding these behaviors so that we can all collectively be met with compassion. And thank you for that little sidebar there. But it's just so important. Tell me, like what do you want to focus on, or like what are your overall thoughts on BFRBs, and where do you see the gaps still in treatment, and where you want to focus next?
So, like I said, I've been working in this area for a long time, and I see we're getting close. So I'll say it in a
Yeah.
right way that um, BFRBs are more difficult to treat, right? And then even what does treat mean, right? Like what are we shooting for? But they're more difficult because it's a enjoyable behavior, and all the enjoyable behaviors are just harder to help someone get control of.
Yeah.
Um, so we've tested out these interventions and we find that they're useful, but I would probably argue at the end they're not quite as useful as we have with other conditions. So like take panic disorder. Um, we we get pretty high success rates with that. And I would say our treatment of trichotillomania is going to be lower than that. So I think we just have to figure out how to build this out to deal with some of the like fighting forces that are in trichotillomania, and we're working on that. Like Mercedes, she's doing really cool work looking at how people with trichotillomania show up in their individual ways, and if we can assess that and track that, then can we take intervention pieces that match their individual presentations. So like work like that. One of my students, Lila, did a really cool study where she did the web-based intervention, then everyone got in-person intervention. And I think there may really be something there because hearing it one way and then hearing it a second way,
Mm-hmm.
everyone really appreciated that.
Yeah.
And then in that, maybe there's pieces different people need, and we have to figure out how to like give the different people what they need in what way. So yeah, I think it's building out the intervention to match the people who are getting it. I think
Yeah.
that's where the work in this lab's going.
Yeah. Yeah. Thank you. Yeah, I feel like you hit a really interesting insight there about it feels good. It feels good in the moment to just go rip, but it's the aftermath that doesn't
Oh
feel
yeah,
good.
yeah,
And that's really interesting because, like, yeah, things like OCD, things like panic, things like anxiety, like, I can speak to anxiety a little bit because, like, I don't like that feeling in my body, right? But this, oh, sometimes I'm not actually doing it, but that is
yeah.
sometimes like it does feel good in the moment. And so that's a huge insight that I think, yeah, like, I know in the habit aware community, we have an online community. We help people through trying to understand and trying to recognize, well, is that really true that it feels good? Like, yes, it does in the moment, but
Right,
we it's not the end of that sentence, right? It feels good. It feels good, but then I feel like crap because dot dot dot, right?
right,
And so it really doesn't feel good.
right.
Um, so yeah, like having that mindset shift, I think really does help people start learning to stop lying to themselves. Really.
Well, I wouldn't feel bad. We all get caught in immediate reinforcers are more powerful than delayed things. So it's a
Mhm.
kind of common human problem.
Yep, a hundred
Yeah.
percent, 100%. I want to be mindful of your time. I know you probably have patients to see or students to chat with,
Yeah.
but I'm really, really appreciative of your time, Dr. Twohig, and I will catch you on emails, and I look forward to doing a training with you again soon.
Uh, well,
Yeah.
thank you, and thanks for everything you do. You, the hugest advocate, and we all appreciate it. Do good work that you do and that we do. And this isn't really a skill that we have at the university. So thanks for doing these things to get the word out.
Yeah, thank you. Thank you so much for the work that you've done in the past to get us here. And I know so much more is to come from your group at Utah
Thanks.
State ACT program. Thank you.
You're welcome.
Bye,
Bye.
everyone. Happy BFRB Awareness Week. Wishing you love, strength, and awareness. Bye. Bye.
Bye.